Hello, so we'll talk about two very important complications which we face during anesthesia, laryngospasm and bronchospasm. Now, both the complication can happen during anesthesia and we need to, especially in the predisposed patient, and we need to identify them and we need to immediately rectify it. Otherwise, patient may land up into more severe respiratory complications. So, in this section, I will talk about what is laryngospasm, what would be the clinical features, why are some patients more predisposed to laryngospasm, how can we prevent it, and how do we manage it. And after completion of laryngospasm, I'll talk about bronchospasm, right? So let us start our discussion with laryngospasm. So what exactly is laryngospasm? What is laryngospasm? Now, laryngospasm is reflex closure of the larynx. And how does this reflex closure happens? By approximation of the true and the false vocal cord, both. We can have absolute laryngospasm, we can have a partial laryngospasm. And definitely the presentation in partial laryngospasm would be less severe, but anytime the partial laryngospasm can get converted into the absolute laryngospasm, right? So what is laryngospasm? Laryngospasm is reflex closure of false and true vocal cords, and this is accompanied by descent of the laryngeal inlet, and this is accompanied by descent of laryngeal orifice. So this can be, as I said, it could be partial. So laryngospasm can be partial, in which there is an approximation of the vocal cords, but complete closure has not happened, or it could be complete. In complete laryngospasm, the complete closure of the vocal cord is seen, right? And anytime the partial laryngospasm can get converted into complete if we don't escalate our management. So we have to be very careful. Now, when can this happen during anesthesia? Is it during only induction or only during reversal? Well, it can happen during any stage of anesthesia. It can happen during induction. It can happen even during maintenance if you have not put the infraglottic airway device. It can happen with supraglottic airway device in situ in patient, and it can happen definitely during reversal also in predisposed patient. So, during anesthesia, the patient can develop laryngospasm during induction, maintenance, and reversal. So, it can happen during induction of anesthesia. It can happen during maintenance of anesthesia. It can happen during reversal of anesthesia, right? So, reversal of anesthesia. So, how do it presents? How do we suspect that patient is possibility of development of laryngospasm? Well, patient would do lot of effort to breathe, and this effort would not get converted into passing of the air as the glottic opening is narrowed or closed. So, on auscultation, when the patient is desaturating because of the lack of air entry into the airway, when we auscultate, even in spite of too much of the patient's effort, the air entry is diminished or absent in complete laryngospasm. Since patient is taking a lot of effort, the inspiratory stridor, we will hear inspiratory stridor, and we will also, let's say, see in the patients the chest wall retraction and rocking movement of the chest wall when the patient tries to breathe against the closed glottis. So, the clinical features. Now, when the patient is going into hypoxia and we start observing our patient, the saturation decreases. What we see in our patient? We see inspiratory stridor, the rocking, the retraction of the chest wall and the rocking movement of the chest wall because patient is breathing against the closed glottis, retraction and rocking chest wall movement. No or very diminished air entry in spite of maximal inspiratory effort taken by the patient. So, no or no or decreased air entry despite inspiratory effort, right? Then because of all these, patient may develop cardiovascular symptoms. Now patient may develop bradycardia, heart rate may start decreasing. This may be due to hypoxia or due to the inspiratory effort, the stimulation of the vagus nerve. Then patient may develop negative pressure pulmonary edema, which is one of the most sinister complication of complete laryngospasm. Patient is trying to breathe against closed glottis. So a lot of negative intrathoracic pressure is getting developed, and because of this increased intrathoracic pressure, the hydrostatic pressure increases and this results in pulmonary edema. The presentation would be same as any other pulmonary edema. That is, the creps would be on auscultation, pink frothy secretion we will see, right? So, and this is more commonly seen in young patients because they can generate such a high pressure that which would result against the closed glottis to open it, which would result in negative pressure pulmonary edema. So negative pressure pulmonary edema, this is happening because patient is attempting, because of the attempt to inhale against closed glottis, and more commonly seen in young patient. And when they develop the pressure, pressure up to -50 centimeter of water has been seen to most. This much pressure has been seen most commonly associated with negative pressure pulmonary edema, and this much high negative pressure intrathoracic pressure mostly is developed by young males, young sturdy people. So that's why negative pressure pulmonary edema is more commonly seen in the younger age group. Okay, now let's say after this, what are the factors which increases the risk of developing laryngospasm in the patient? Now, as I said, induction, maintenance and reversal, it can happen during any stage of anesthesia. So what are the predisposing factors, right, that increases the risk of laryngospasm during anesthesia? There are a lot of actually predisposing factor. The age is one of the factor, type of surgery patient is undergoing is one of the factor, then our approach of airway instrumentation, how much stimulus we have given, what kind of stimulus is resulting in the laryngospasm is the factor. So let us see what are the factors, and these factors we have to take care to avoid presenting in a patient. So airway instrumentation during light anesthesia, when we are trying to do laryngoscopy and the plane and the depth of anesthesia is not deep, I'm trying to do laryngoscopy in a young patient without giving a neuromuscular blocking agent. Number of times in pediatric patient we try to intubate without paralyzing the patient, and if the plane is light, the risk of developing laryngospasm is high. Then vocal cord irritation by inhalational like desflurane, which are the irritants, the respiratory irritants, or blood or the secretion, right? All this can cause reflex closure of larynx. Larynx protects the airway. So any irritation on the larynx would result in the reflex closure of the larynx. That's the natural defense mechanism of our body, which is protecting against protecting the lower airway of the patient. So these can cause the laryngospasm. Then young age, as I said, age is one of the factor. Younger the patient, more is the risk. Infant has the highest risk of developing the laryngospasm. Then recent or current, let's say, respiratory tract infection. If patient is already having URTI or has a history of a recent URTI of less than 6 weeks, the risk is higher. Then passive smoke exposure. Patient, one of the parents is a smoker, and a patient has a passive exposure of the smoke. Then obstructive sleep apnea, if it is associated in the patient. Airway anomaly increases the risk of laryngospasm, and type of surgery, that is airway procedures like tonsillectomy. These increases the risk of laryngospasm. So how do we manage it? We have to do an immediate management. It could be partial, it could be absolute, and management should be in a sequential manner, one after another. So whenever I see a patient whom I suspect that laryngospasm has developed, how do we manage? So first I will see patient is desaturating. So natural thing which we do when we see a patient desaturating, make the oxygen 100%. So first step would be that I will make 100% oxygen. I will give 100% oxygen to the patient. Then now after this, I will put the mask on the patient's face, on nose and the oral cavity, and make a tight seal and try to give a continuous positive airway pressure through anesthesia machine at the pressure of 20 to 30 centimeter of water. So obtain tight seal, tight mask seal, and give continuous positive airway pressure with a jaw thrust, and how much pressure we should give at this point of time through the anesthesia machine. We should turn the valve of the anesthesia machine at 20 to 30 centimeter, between 20 to 30 centimeter of water, right? Now after this, what we can do, we can apply a pressure over laryngospasm notch, something we call laryngospasm notch or Larson's notch. We can do something called Larson's maneuver. Now in Larson's maneuver, now the end point of the ascending ramus of the mandible, the superior point of the ascending ramus of the mandible, and the junction of the mastoid process. At the junction of the superior end of the ramus and your mastoid, we apply a pressure. So I'll just show you how do we apply this. This is the point. This is the mandible. So superior ramus of the mandible, at its junction with mastoid, we apply a pressure. This is called Larson's point, and we call it Larson's maneuver, or sometimes it is also called laryngospasm notch. So we apply pressure with fingertips to the laryngospasm notch, and this is called Larson's maneuver. We can deepen the plane of anesthesia. So deepen the plane of anesthesia. It always happens during the lighter plane. So deepen the plane of anesthesia. Now don't try to give the agent which can be irritable, airway irritant like desflurane for deepening the plane. Use either sevoflurane or the IV agents like propofol, right? Both are very good in deepening the plane of anesthesia and are fast acting. And if no improvement in spite of all these 4 management, what we do, we try to paralyze the laryngeal muscle which has caused the reflex closure of larynx. So we can give a neuromuscular blocking agent like succinylcholine. Like succinylcholine not? Definitely succinylcholine. Why succinylcholine? Because it has fastest onset, and when I have to open the larynx, right, then we need to use the agent which is fast acting. We don't have time, patient is already going into hypoxia. So succinylcholine is one of the emergency drugs that we always keep prepared to treat the laryngospasm. So we can give, if no improvement, we can give succinylcholine. So succinylcholine, what is the dose which we use? We can use 0.2 to 0.5 milligram per kg body weight. And be very careful. One of the side effects of succinylcholine is bradycardia. If patient already has a heart rate towards lower side, accompany it with atropine. Now always use atropine, don't use any other antivagal because atropine is the faster acting. So use it in 0.02 milligram per kg body weight. Okay, we simply give let's say 0.02 milligram per kg body weight along with succinylcholine, right? Now this, after let's say paralyzing the patient, if already patient doesn't have a supraglottic airway device, or if patient is not intubated, we may intubate the patient or put a supraglottic airway device. We can even put a supraglottic airway device. So 6th thing which I will do is, I will put a endotracheal tube or a supraglottic airway device and ventilate our patient. Okay, so this is how we manage the laryngospasm. So just in a flow chart, perform? So we first need to identify the laryngospasm by seeing presence of inspiratory stridor, tracheal tug or tracheal retraction, and paradoxical rocking movement of the chest. Now we need to intervene immediately. First, what is causing the laryngospasm? We have to remove that stimulus. So whether it is the lighter plane, our airway instrumentation, or the secretion, what is causing? If we are doing some airway manipulation at that time, we have to stop that manipulation. We have to deepen the plane of anesthesia and then do that manipulation again. If there is some secretion or blood in the oral cavity, we have to suck it off. So remove the stimulus, stop the noxious stimulus like airway manipulation, or let's say suction any secretion or blood if it has been pooled in the oral cavity. 100% oxygen, CPAP by face mask with jaw thrust, neck extension and mouth open. All this will open the airway. Laryngospasm notch pressure or Larson's maneuver, which I just now discussed, we can apply that. And we can put an oral airway if it is necessary after deepening the plane of anesthesia. If you haven't deepened the plane of anesthesia, the oral airway can further cause the stimulation. Now, after doing all these maneuvers, we will again auscultate the patient. Is the patient having any air entry? If patient is having air entry, then it's an incomplete laryngospasm. We will deepen the anesthesia with propofol or sevoflurane. We reassess the patient. If patient has improved, the air entry has increased, the chest wall retraction, etc. is not now seen in the patient, we can proceed with our procedure. But if there is no air entry after our initial interventions, then it is a complete laryngospasm and it's very much an emergency. Immediately call for help, and in this administer the propofol if patient to deepen the plane of anesthesia, positive pressure ventilation, and we can here give succinylcholine to the patient, and we can try to open the larynx, open the vocal cord. Okay. Now, if there is no improvement, as I said, we can give succinylcholine 0.25 to 0.5 milligram per kg accompanied with the atropine, if bradycardia, heart rate is less in the patient. Ventilate the patient by mask or supraglottic airway device or ET tube. As long as the patient is under effect of neuromuscular blocking agent, we can proceed with the procedure, because once we have paralyzed the patient, the vocal cord will definitely open, and that is the last resort. Now, when we have extubated the patient and then the laryngospasm has developed, this is something which we do definitely at the end of course, right? Because we are planning the reversal of the patient. If the patient improves by deepening the plane of anesthesia, let's say by applying the pressure on the Larson's notch, then definitely that would be better rather than using succinylcholine. But if it's a complete laryngospasm and the vocal cord is not opening, patient is desaturating, heart rate has started decreasing, give the succinylcholine accompanied with atropine immediately. That will open the larynx. Okay, so this is how we manage the laryngospasm, right? Now, how can we prevent this laryngospasm from happening? Because definitely most of the cases we can manage it. Uncomplicated management we can do, but it can develop in complications like negative pressure pulmonary edema. So we need to avoid it from happening. So we have already discussed the predisposing factors. We need to prevent those predisposing factors. So prevention of laryngospasm. If patient has a recent URTI, delay the elective surgery, especially in children. It is more commonly seen in children. Then suction, nasal and oropharyngeal secretion when the patient is deeply anesthetized. Number of times when we are inducing the patient and we see the secretion, still the plane is not deep, we start doing the suctioning. That can also precipitate laryngospasm. So we need to avoid that. Perform laryngoscopy or intubation or insertion of supraglottic airway device in the deeper plane, always in the deeper plane. See, supraglottic airway device requires a lighter plane to tolerate it in a patient. But during insertion, the depth should be deep. Otherwise, it is one of the reasons why patient can go into laryngospasm. Then avoid extubation or airway manipulation during light level of anesthesia. Removal of endotracheal tube or supraglottic airway device should be done either in patient who is awake or under deeper plane of anesthesia. Right? Deeply anesthetized patient, we can extubate and do a mask ventilation. Or when the patient is awake, never do in the lighter plane of anesthesia. For children over 1 year of age, try to use supraglottic airway device as much as possible rather than ET tube, right? Supraglottic airway device is less associated with this complication. And administer muscle relaxant for intubation. If you can give neuromuscular blocking agent before intubation, always deepen the plane of anesthesia, paralyze the patient, and then attempt laryngoscope in intubation. Under lighter plane, laryngoscope very much predisposed to development of laryngospasm in the patients. So we need, these are the measures by which we can prevent the laryngospasm from happening. Well, it's a complication which we very commonly encounter in our anesthesia practice, especially in pediatric age group. If we know the sequential management, how to prevent it, how to identify it, then definitely we can prevent it from leading it to major complications, major respiratory complications in the patient, right? So this is all about laryngospasm. Now let's talk about another complication, that is bronchospasm. And here I would talk about intraoperative bronchospasm. How do we identify it? How do we manage it? So when the bronchospasm develops in intraop patient, what would be the clinical features? What would be the clinical features? So clinical features which I am discussing is sign under anesthesia, right? So if patient is, let's say, awake and has developed bronchospasm, they will definitely complain respiratory distress. But under anesthesia, patient will not complain respiratory distress. Patient is anesthetized. So what are the signs of bronchospasm under anesthesia? Well, definitely wheeze on chest auscultation, the change in the graph of the capno, tidal volume which was being generated in the patient, it has decreased, inspiratory pressure has increased, and oxygen saturation of the patient has decreased. So when the patient's oxygen saturation decreases and the inspiratory air pressure, high airway inspiratory pressure, high inspiratory pressure, and despite of high inspiratory pressure, decreased tidal volume, we auscultate the patient and we find that wheeze on chest auscultation, right? And definitely when we have attached the capno, we will see the change in the capnograph, right? Capnography image, from normal it will change. There's a typical shark fin pattern what we will see, upsloping of EtCO2 waveform. And if the bronchospasm is very severe, then we can see a decrease in the EtCO2 or absence of EtCO2 waveform. So we can see severely decreased or absent, let's say, graph also, if the bronchospasm is very severe. So how does this shark fin or upsloping of the EtCO2 waveform looks on the monitor? This is something like this. This is called shark fin pattern, right? And this is seen in obstruction. So bronchospasm is causing obstruction for the air to pass, and this will result in shark fin pattern. Now definitely more the obstruction, more would be the upsloping. So it could be sometimes a gradual upsloping, or it could be a very steep upsloping. More the upsloping, more is severe is the bronchospasm. And in complete bronchospasm, we can see a flat line of course, or a very severely decreased EtCO2 graph. So remember, when you see this along with these clinical features which I just now described, that is decrease in oxygen saturation, high inspiratory pressure, decreased tidal volume, wheeze on auscultation, we should suspect bronchospasm. Now, when we suspect bronchospasm, how do we manage? What is the management plan? So, management immediately, like any other intraop hypoxic condition, we have to give 100% oxygen. So, FiO2 is increased. FiO2 is increased to 1. That is, we give 100% oxygen. Immediately, if the patient is being ventilated by ventilator, take the patient on bag to check the chest compliance, to assess the compliance and the excretion. So, hand ventilation, start doing the hand ventilation to assess the compliance, right? Now, there are certain intraop complications which can mimic the bronchospasm, clinical features of bronchospasm. We need to rule out those differential diagnosis of bronchospasm. So what could be the DDs of bronchospasm? So during management, we have to establish it is really bronchospasm, because if it is some other condition, the management would be different. So endobronchial intubation. This is one DD of your bronchospasm, endobronchial intubation, because in endobronchial intubation also there would be a decreased air entry or complete absence of air entry in one side of the chest. And if you just see the ET tube clinically, it is deeper than what you had fixed during initiation of the surgery. So endotracheal intubation, decreased breath sound on one side. In bronchospasm, there would be decreased breath sound bilaterally, right, or absent breath sound bilaterally. Here it is decreased breath sound on one side or absent breath sound on only one side. And deep ET tube. The ET tube is deep. Then pneumothorax. The second DD is pneumothorax. So pneumothorax, how would it present intraop? Again, it's unilateral pneumothorax, so decreased unilateral breath sound, asymmetrical chest rise, very high inspiratory pressure, high peak inspiratory pressure, and correlate with the clinical scenario. Something happened just prior, that patient developed these clinical features, right? So decreased unilateral breath sound, asymmetrical chest rise, high peak inspiratory pressure, and we need to correlate it with clinical scenario which has led to this. Then the third DD can be your pulmonary edema. So third DD can be your pulmonary edema. And in pulmonary edema, what we will see, we would on auscultation, we will hear the creps and pink frothy secretions. So frothy secretion, typical hallmark of pulmonary edema. Then crackles on auscultation, right? Okay. Then there is a chance that if your ET tube gets kinked, then also it may mimic the clinical presentation of bronchospasm. So whenever, let's say, we suspect bronchospasm, we have to see the entire attachment of the patient's tube, circuit, everything. So even sometimes kinked ET tube, kinked or obstructed ET tube can mimic the clinical presentation of bronchospasm. So we have to rule out all these clinical features. So once we have ruled out all these clinical features, how do we manage bronchospasm? So bronchospasm, what has happened? The caliber of bronchus has decreased, right? So as I said, already I have made the saturation 100%, taken the patient on hand ventilation, right? Then we can deepen the plane of anesthesia. A lot of anesthetic agents which we have, they are very good bronchodilator. They relax the smooth muscle and they cause a very good bronchodilation. Your halothane, sevoflurane, they are very good bronchodilator. Propofol is an excellent bronchodilator. Ketamine is a very good bronchodilator. So we can use any of these drugs for immediate deepening of anesthesia and bronchodilation. So next thing, deepen the plane of anesthesia by a bronchodilator anesthetic agent like sevoflurane. If it is not a complete bronchospasm, we can use very well sevoflurane, or propofol IV would be better, because if bronchus is constricted, there would be decrease the let's say gases would go with little difficulty. So propofol or ketamine we can use. Then immediately, if patient doesn't get relieved by this, we can use a short acting beta agonist like albuterol. We can use it through a nebulizer or through a metered dose inhaler. But be careful in giving 8 to 10 puff, because most of the medications would be left in the tube itself. So we can give short acting beta 2 agonist. We can give short acting beta 2 agonist like albuterol. And if I am giving by metered dose inhaler, should give 8 to 10 puffs, minimum 8 to 10 puffs. Okay. We can give anticholinergic. We can use anticholinergic agent, right? Anticholinergic. They are very good bronchodilators, like your atropine, your glycopyrrolate. Just be careful that if it's an old patient and they cannot tolerate an increase in heart rate, we have to be careful. Otherwise, in younger patient, very well we can use glycopyrrolate and atropine, any of it. So we can give glycopyrrolate 3.2, the dose is 3.2 microgram per kg, or instead of calculating like this in emergency, always I give 0.2 milligram IV. Okay, so just give 0.2 milligram IV. Or we can give atropine. The dose which is described is 6 to 10 microgram, or let's say 0.4 milligram we give, right? We can give anticholinergic by your nebulization. Ipratropium we can use. So we can even give ipratropium, let's say 500 microgram through nebulizer, 500 microgram through nebulizer, right? Or the metered dose inhaler of ipratropium, 4 to 8 puffs we can give, 4 to 8 puffs. Okay. The onset time of this is 20 to 30 minutes. So always accompany with some fast acting way of bronchodilation, and your anesthetic agent would be wonderful in that, right? Then we can give for refractory bronchospasm. Remember one drug for refractory bronchospasm, epinephrine, a very good bronchodilator, right? So epinephrine we can give for refractory bronchospasm. So what is the dose of epinephrine? We can give it through bolus, 10 to 50 microgram IV, or start an infusion. I would rather start an infusion. So 10 to 50 microgram IV or 2 to 10 microgram per minute infusion. Then another wonder drug would be magnesium, very good bronchodilator, 2 gram stat I will give. Remember, it is a vasodilator also, so blood pressure may decrease. So be careful in managing the blood pressure. So we can give magnesium 2 gram IV over 20 minutes, Just be very careful in observing the blood pressure of the patient. Steroids we can give, glucocorticosteroids. Just remember that it takes some time to act. So the other faster acting agent like beta agonist, anticholinergic drug should be given immediately, because it will take some time to act, and we have to give high dose. So hydrocortisone we can give hydrocortisone 100 milligram IV, or methylprednisolone 60 to 80 milligram IV, or methylprednisolone 60 to 80 milligram IV, right? So these are the interventions which has proven benefit and has shown to be a very good bronchodilator. There are some more, let's say, intervention which has been described but not so commonly used and has not shown to be of a proven benefit. I'll just mention those. Some studies have shown the NTG, use of NTG, that can be, the NTG also causes a very good bronchodilation, but not very commonly used. So other intervention which has not proven, which doesn't have a proven benefit, we can use NTG. Heliox, that is helium plus oxygen. Now this has no role in bronchodilation and it only gives 21 to 24% oxygen. But Heliox, by adding helium to oxygen, the ease of oxygen administration increases. So this can be one of the way of making the oxygen reach the patient, right? But it doesn't give a higher oxygen concentration, only 21 to 24%, and it has no role in bronchodilation, right? And if patient does not improve, it's a severe refractory bronchospasm, then we may have to take the patient on ECMO also, right? But that is the last resort kind of thing and not available everywhere. If we just do the management which I described, the routine management, the patient definitely will come out of the bronchospasm. Anesthetic agents are very good bronchodilators, so we need to use them judiciously in this condition. But we have to be careful we have to manage the blood pressure of the patient, because dose-dependent hypotension is also caused by these anesthetic agents, which are good bronchodilators. So what do I do when I use anesthetic agent? I use propofol and ketamine combination, because ketamine would counteract the vasodilatory effect of propofol, and I would get a very good bronchodilation without having any hypotension. Okay, so this is how we manage intraop bronchospasm. So we discussed two important complications which we can face in intraop laryngospasm and bronchospasm and their management. I hope you have understood. Thank you.